Good afternoon, everyone. My name is Adamika Arthur, and I run a nonprofit organization called Health Tech for Medicaid. I hope many of you know what Medicaid is. There are some people running large systems in this country that don't know the difference between Medicaid and Medicare, but I can teach you if you'd like to know. We are going to do a workshop today, and we were given this time slot today that it's experimental. We try really hard to do a session on capital markets and Medicaid, and we have for the last 3 years now. And usually we do the 3 o'clock session. And Grant and others have experienced this. And the 3 o'clock session usually is full to the brim and around the corner and outside the room. And so they wanted to see if they would try the 12 o'clock session. I was like, my flight never gets in on time at 12 o'clock. And you literally experienced that. But we still have quite a few people in here. So we'll work at the 12 o'clock session. So we are going to do some tabletop exercises, but this is supposed to be interactive because we often don't talk about these conversations together. And the reason why we started talking about these conversations is because if we don't, in the community, we often never talk about capital markets. In capital allocators often never talk about Medicaid. And innovators often are caught in between either the teeter-totter or the pull. Either they want to serve the Medicaid market and are told by others, depending on either their customers or their investors not to, or it's too complicated or whatever, or the opposite. They're maybe asked to serve this market and then they resist or don't want to. And so we're here to do myth busting. So the last session, which was at Health, I want to tell you, we had a lot of chairs up here and we did something very novel and unique. I sat in the middle, and on the left of me, I had 3 venture capitalists. And on the right of me, I had 3 representatives representing federally qualified health centers. I sat in the middle because I have a unique background. I'm an epidemiologist by training. I also am known for writing state policy that became very large national policy. Probably doesn't matter now. But I wrote the first 1115 waiver in California, which is the first set of policy that expanded Medicaid in this country, which helped in the ACA to expand Medicaid through the 1115 waivers in the country. We'll see what that means in our current climate. That turned me into a hospital administrator. Longer story. I ran hospitals for 15 years, but while I ran hospitals, I also ran 3 federally qualified health centers. So I have run federally qualified health centers. While running Health Tech for Medicaid, I learned how to be a venture capitalist because I could not figure out why. We had a venture council, and we would meet, and I felt like I was not understanding the alphabet soup of what they were giving me back as to why I was in the middle of that tension point. I felt like I was throwing things one way and they were throwing things back to me. And so I took a year out of running the org and learned how to be a venture capitalist. And so I did the VCI program and the Stanford program, partially because I live on the West Coast. And so you're not good enough somehow unless you've gone through the Stanford program. So I did go through the Stanford program. And so I sat in the middle because I could identify and understand the language on the left and the language on the right. And the one thing we learned in that session is that the left still had a lot of misconceptions on what was on the right, and the right had a lot of misconceptions on what was on the left. And it was fascinating to watch it play out on stage. We have it taped if you ever want to see it. And so today we're going to do something to build on that. And so we try really hard to continue to build on these lessons. And so today I'm going to bring up an impact investor and an academician who's also a clinician. And we are going to talk about capital markets, innovation, and community. And then we are, in the audience, going to have these conversations with these multidisciplinary folks at these tables, all of us, and we hope that we will be asking very difficult and hard questions. So everybody down? All right, let's do this. So I want you to feel permission to ask difficult questions, because the only way we are going to actually make change for the now 79 million people on Medicaid and their caregivers is by pushing the system a little bit. And the only way we're going to make sure that our capital markets are growing effectively and efficiently is by making sure they're serving lots of folks, right? It was a very exciting JPM this year. I think a lot of people feel like our markets are going to be tested in a good way and we're going to make some money, right? In this new administration. It's very exciting for PE and markets, right? So if we're going to make money, we want to make sure we're making money kind of ethically and inclusively, at least from my perspective, right? All right, good. Here we go. I think I talked a little bit about Health Tech for Medicaid, but we're really a nonprofit organization on a mission to radically change the pace of Medicaid. Who knows a little bit about Medicaid in the room? Because if all of you know a lot about Medicaid, I can skip this slide, but literally if one guy raised his hand, then I probably need to go through a little bit of this slide. There are 79 million individuals on Medicaid as of now. That was a huge number during the pandemic. There was a little bit over 94 million individuals on Medicaid. The reason why that number has dropped significantly is because of Medicaid redetermination. And so we actually don't know where about 20 million people are, and we may not know for a while. We don't know if they're uninsured. We don't know if they're on the state exchange. We don't know where they have actually gone, because that data may not be available to us moving ahead.
Do you think you need to explain what the redetermination?
I can. Yeah. And Medicaid redetermination is still happening. So basically, in COVID-19, we all remember COVID-19, right? Yeah, a little bit of PTSD. So in COVID-19, one thing that did happen is there was an intentional pause that basically if you were on Medicaid and you got on the program, you were kind of given a stop unless you asked to be taken off because you got a job or something happened, life event happened, and you asked to be taken off, which many people did, right? They got a new job or they moved to a different state, which lots of people moved during the pandemic. So those individuals, about a year and a half ago, we started a process called Medicaid redetermination, which is really a computer system in each state. Medicaid is done 56 different ways in this country because it is a state and federal partnership. You may remember about, 17 days ago, there was a real pause, a true pause in this country for the first time ever. Our Medicaid systems shut down, literally no payments, nothing was able to happen. And that was the first time that's ever happened. So that Medicaid redetermination system is a computer systems in each of the state are determining when people's renewal happens again. And so people have to recertify their information. So some people have their information available and ready, and some people don't. And there's been, as there is with any computer systems, right, some errors. And so Medicaid redetermination was supposed to be finished April of 2024. And we've had so many challenges in the country, they've extended it to May of 2025. And I don't know what we'll do. But that's what the Medicaid redetermination process is looking at how we can better find the people who've been kicked off of Medicaid because of, so there's a gap between individuals who are on Medicaid today and those people who were on Medicaid during the pandemic. Does that make sense to folks? Okay. 1 in 5 individuals in this country are on Medicaid. 50% of children. About almost 50% of births in this country, so 50% of babies born in this country are on Medicaid. Large amount of people. When you go into the grocery store, think of, there's 5 people in line. One of those people is on Medicaid. And depending on what state you're in, that can look completely different. So if you're in California, where we live, 2 of us, 1 in 3 people are on Medicaid, right? So that can look different depending on where you live across the country. All right. Well, I will answer what is the difference between Medicaid and Medicare. Medicare is individuals who are over the age of 65 in this country. Medicaid and Medicare have the same birth date. They were born on the same day. Medicaid and Medicare will turn 60 in July of this year. Okay? There are people that have both Medicaid and Medicare. They are called dual eligibles or Medi-Medis. Okay? So Medicaid is a birth to death system. So, remember there was a big tagline many years ago, Medicare for all? We already have that system. It's Medicare. Medicare pays for almost 90% of the palliative care programs in this country. End-of-life care. End-of-life care, 90% of that is paid for by Medicaid. So, 60 years ago when these programs were started, we called one care, we called one aid. Medicaid started as a women and children's program. Aid means help, doesn't have the nicest connotation to it. Care means to help, care, sounds lovely. That's for individuals over 65. Make sense to everyone now? That's the difference between Medicaid and Medicare. So if you see RFK out there, you need to help him out. That is the difference between Medicaid and Medicare. Just want to make sure you know. Okay, so today we're going to talk about community and capital markets. I think most people know what community is. We all live in community together, right? Most people know what capital markets are, right? They're financial markets where securities, stocks, bonds are bought and sold, right? And there's a range of community markets, of financial markets, right? From impact investing all the way to private equity. And you can, we all have banking, et cetera. Last session, we showed this slide, which is how the safety net can collaborate effectively with innovators. And I just wanted to re-educate folks on kind of what we called the 4 C's last time. You can contract. If you're an innovator in the room, you can contract or partner with innovators, right? You can co-invest, right? You can co-build, and you can co-design. And you can actually do all of those, or just a few. This we'll go over at the table, so I'll maybe get to that later. And I think we'll go over this stuff later. Let's get into the panel. Okay, so I'm going to start with you, Christian. Why don't you introduce yourself to the group?
Sure, yeah. First up, I think this is a really important discussion we're having, and we really are at this pivotal point in history, in my opinion, where we have both really exciting advancements in technology that can be leveraged to impact our communities in an unprecedented way. And then we do have a lot of change happening, and people in this room, I think, are the ones that can help guide that change in the right direction. But I'm Christian Payan. I'm an orthopedic trauma surgeon at Duke University School of Medicine in Durham, North Carolina. The other hats I wear in Durham, I'm the director of IT and AI innovation for the orthopedic surgery department. And then I'm a core faculty member at the Duke Margolis Institute for Health Policy. And I, for a long time, have been very interested in the intersection between community and capital, and I'm excited to dive into that with you. The other hat that I wear is I'm CEO and co-founder of Redefining Health, a generative AI care navigation and virtual care platform focused on pairing clinical care with social care in musculoskeletal patients. So that's who I am, and I'm excited to dive into all of these topics with our panel today.
Amazing. You, Lily?
Yeah, good morning, everyone, or good afternoon. I'm Ulili Novapuri, a managing partner at Cape Work Capital. We are a venture capital firm that's based in the San Francisco Bay Area. We specifically focus on early stage investments, so pre-seed, seed, and Series A, companies who are looking at addressing low-income communities and communities of color. Our companies don't have to just focus on those folks, but they have to make sure that their product is accessible to those communities. And when you were talking about Medicare, Medicaid, it reminded me of growing up in San Francisco, they had Medi-Cal. So it was another one. If you're, I don't, RFK would be probably a little, that'd be too much for him. But as someone who came from that community, growing up low income, and we used Medi-Cal, and the program was a lot fuller back then. I think there's unfortunately been cuts since then. This is something that's definitely close to my heart.
Yeah, and that's actually a really great call out. Before the session started, I was talking to a woman in the back of the room. We were talking about state programs. So because Medicaid is a state and federal partnership, a lot of states have branded it themselves, right? So it's called something, it's not called Medicaid in any state, really. It's not called Medicaid. It's called something else. It's called Medi-Cal in California. It's called it's called something different in every single state. And so, well, not every
and even cities. So San Francisco, where I grew up, calls it like San Francisco Healthy Families.
Yeah.
Yeah.
It's still called Medi-Cal,
Yeah.
but yes, there are some municipalities that have additional services that are added on to. Yes, but and you go to Massachusetts and it's called in some states it's called Maine Care, and I mean, so every state has their own. In Georgia it's called Peach Care, and so that is another thing that's a little confusing to folks, right? It's also, we have Medicare in the territories, right? And people don't quite understand that. So in Puerto Rico and in the Northern Mariana Islands and in the Virgin Islands, we have Medicaid. So let's jump into something that's quite sexy and we hear about all the time. Where I'm going to jump into AI, right? The reason why I'm going to say this is because the one thing I keep hearing is if you put AI on your slides as an innovator, you're almost like any of the capital market, like any of the venture capital firms, you'll get, if you put AI on your slide, AI mediated, AI assisted, AI powered, you're almost always going to get funded. Tell me a little bit about the sexiness of MLL and AI and the rabbit hole we may have created. And Grant is smiling over there, but he has a white paper coming out now that is going to be explaining a lot of this AI craze. But tell us a little bit about the AI craze and why people are, whether it's performative or not, they're putting AI on everything. And what do we do about this?
Explaining or exposing, right? I think that, yes, generative AI in particular is really exciting. Certainly, and I'm an innovator in the space, and I'm obviously interested in applying it to patient care in the right way. There are a lot of pitfalls, though, that we have to avoid. And the bottom line is that the generative AI, the machine learning algorithms that we use are only as good as the data that we put into them. And bad data in, bad data out. Some of my early research when I was in my fellowship was looking at some of these machine learning algorithms and how they don't perform the same in different racial and ethnic groups and how that can bias the outcomes that you're going to impart on your patients. Having said that, putting AI in your slides makes it easier to raise money. That's for sure. but I think that my experience was that if you put AI and social care next to each other, maybe your valuation all of a sudden goes down, and I think that's problematic. I would love to hear your opinion. I mean, I think that there is tremendous untapped potential in this technology as long as we use it correctly, but we have to kind of make sure that we understand that the models don't perform equally in all subgroups. There's going to be a huge trust and credibility problem that comes from this technology, especially if we're using it in the communities that could benefit the most from it. And then the other pitfall is that I think that if we just err towards using this tech and rolling it out, it really does have the potential to exacerbate rather than enhance the disparities that we're trying to solve for.
I'm going to take a poll from the room really quickly. So how many people in the last, 16 days has gone through their decks and taken out health equity out of all their slides?
Come on now.
I mean, be honest.
I mean,
here.
look, I was at a
because
talk.
I mean,
I'm afraid
I think that's one
should
thing
have a
that we're going to
candid
have to
conversation.
have this real conversation about, because health disparities is a part of health care, right? I don't know how we're going to address this. Health disparities is a part of health care, but health equity has now turned into a bad word.
It's a huge problem.
Right?
Yeah.
And so what are we to do with this? Are we to take health equity out of slides? Like what does a company like your company do? What does an investor like you guys do? You're looking at underlooked communities, which by the way there are, right? Like what do we do? Do we all of a sudden forget that there are communities where Native Americans live? Do we forget that there are, and I'm not being crass here, I'm being honest, right? Like I actually wrote this morning, I stopped in Chicago on my layover. And anyone who has my Instagram handle, which is Madam Medicaid, by the way, I wrote a short, because I find Chicago to be the city where people have fled to, always. Right? It is a place where immigrants have fled, and it was a place that people fled to during the gold rush, and people have fled to during, but we are in this tension place. How do we address it? Yeah. It's kind of this tension between fear, but how do we deal with reality? Like, what are we going to do? Healthcare remains. There is disparity in care. What are we going to do?
Yeah, and look, and I mean, what I'll say, and I'm a surgeon, and I run a lot of our population health initiatives at Duke. I mean, health equity is health, and you cannot do health without health equity. And if you do, you're making a mistake, not just morally, but honestly, like you're setting yourself up for failure economically as well.
It's a business.
It's a whole, and I say it all the time, it's a moral mandate, it's an economic imperative, and that's real, and there's plenty of data, right? Like Edward Deming, economists used to say, in God we trust, all others must bring data. and I think we've got to bring more data to the table. We've been showing the data for a long time. If you're a patient from a high area deprivation index decile region, if you're a dual eligible patient, you're about 30% more likely to utilize post-acute care services after an orthopedic surgery. You are twice as likely to come back to the emergency room. You're 3 times as likely to go to an inpatient rehab. I mean, each one of those things has a sticker price on it too, right? Each ED revisit is $900 to $5,000. Each readmission is $37,500. Each extra day that you stay in the hospital is another $20,000, $30,000, right? And especially as we're moving to value-based care, like, in my opinion, if we're actually going to make a difference in healthcare, then I want to maximize my margin, right? Like I don't want to focus on the group where I'm going to be able to take my readmission rate from 2% to 1.7%. I've got this other group that has a readmission rate of 8 to 11%, and then I can take to 3% and make $2 to $4 million on a panel of 800 patients very quickly. So I think that message has to get hammered in. I do think that we're going to face a little bit of a terminology challenge, candidly, right? And there's people that I've spoken to who have health equity in their title, and it's existential. Do you start calling it population health? If you do, is that going to start to become triggering? I don't know. But what we can't forget is that you cannot do health without health equity, and I think we just have to continue to push and make it clear to people that there is a huge market opportunity by doing that. And that's what we've done at Redefining Health. We, candidly, sometimes I have to bury the lead, especially with some groups that we sell into, less so with investors. I'm pretty upfront. I say, hey, I think that if you're sleeping on this, then you're just missing a huge opportunity.
Yeah, I mean, I feel like how can we find each other if people are not putting it in their deck? And it's reevaluating the term health equity. It's the idea that certain disease states impact certain populations more than others, differently than others. And if we say we want to make the country great again, we want to remove kind of those inequalities that exist. For us at KPOR, one of the big disease areas we focus in are disease states is maternal health. Yep. 3x higher morbidity, mortality for Black women. And if you don't acknowledge that, if you don't acknowledge there's a problem, you can't fix the problem. And also to your point as well, it's like if you are a health insurer and you're seeing higher readmissions rates for one population's, higher morbidity rates for one population, and you turn a blind eye, you're not only having worse outcomes, you're having increased costs. So it's not just the right thing to do. It's there's a business case there as well. With that being said, I do tell folks, our founders, when they raise their initial funding from us, they then go out and raise from other investors. I say you should have different decks. For a more impact-focused venture capitalists, you want to have like maybe 3 or 4 slides that kind of details why it's important to you. For folks who that may not be their priority, maybe the terminology is a bit different and it's a slide. But also, too, I never tell them to take it out of their deck entirely, because you have to choose, venture capital it's a marriage. And so if you bring someone into this relationship and they're not values aligned with you, I feel like you're starting with failure from the beginning, because they won't understand the problem. They won't understand what you're trying to solve.
Yeah, and our tagline is better care everywhere for everyone, and that's not changing, right? And I think it's interesting, like you were almost kind of highlighting a code switch, a code switch that's happening in the capital. How many people here are capital market adjacent or venture in the room? You don't have to if you're scared to. Yeah. So I think I will say, like, what I have done is definitely emphasize things like labor market constraints, force multiplier, operational efficiency. That ends up being at the front of my deck, and then I still at the end have like, where is the opportunity greatest for that? And it's in the social care space. It's in this patient population. There's a lack of innovation, but it is interesting, and I'm really excited to get everyone's opinions in the room on what their perspectives are. And we haven't gotten to the nitty-gritty of policy yet and what may or may not stay the same. There've been some really great so there's been some great momentum in the opportunities to have reimbursement for some of these services, and how that may or may not change and how people are going to adopt to it is something I'm hoping we get into as the day goes on.
I'm a little worried about data, and I'm biased. I'm an epidemiologist, so I do my grocery list with a 2x2 table. It's an occupational hazard, but I worry if health equity is not valued as much. We've already heard about things such as gender, right, not being, like, even if we collect data, maybe disaggregated data is not important anymore. Then if we're not collecting the data and we're not using disaggregated data, then you actually can't see disparities. And so
we got to collect the data.
I'm just a little worried about.
Well, I also think that, you mentioned someone, RFK Jr. has been confirmed. And so I think
Thursday.
It's going to change the landscape. We've already started seeing the land right across the hall is like the global health, folks they're meeting. So thank you if you chose us instead of them, but love them too. But I think, we've already seen kind of the defunding of USAID. Yeah. What I feel like it's kind of an opportunity for other folks to step up. It's an opportunity, for the capital market folks to step up. It's an opportunity for the philanthropic folks to step up as well, because we have to fill these gaps. Like if, the government decides to stop funding condoms, or AIDS research in Africa, AIDS is still going to exist. Like these problems don't just magically go away; they still are there. I think for me, the question then becomes like, who steps in to fill the place and who collects the data? For all of our founders, we are we double down on owning the data and the data actually as an asset. And so when they're signing their contracts, either with a payer or provider, that's the first question I ask is like, okay, for the folks you're serving, do you guys own the data, or do you have like, an eternal lease? Because I feel like there's so much power, there's so much potential income in that data. And especially as traditional data sources start to fall by the wayside, we have to make sure that we're stepping up.
All right, so we've talked about AI. We've kind of sidestepped.
Can I go to AI really quickly?
No, please.
So I maybe am a little bit of a skeptic. When I see AI in a deck, I'm like, but why? Like, like I feel like AI is what blockchain was, like, even then I'd be like, but why? Why do you have a coin? Like, I don't understand. You are a mental health company. What does this coin help people do? And so now it's like, why do you have a chat bot? What does the chat bot help? Like, and so
does it how are you making sure it's not exacerbating or creating more harm?
Yeah.
What are the guardrails in which you're making sure that's not unintentional harm?
Yeah, what training data are you using? How are you protecting your patients' input? So I'm funding less things that have AI unless the folks can say, this is why we're utilizing AI. This is how it's kind of a multiplier effect for what we're building.
Well, yeah, and I totally agree with that sentiment, actually. And I think that a lot of people are slapping AI on everything, and it's not the right thing to do in many cases. And look, we are a company that uses voice AI agents. Like, a lot of people don't like talking to AI still. I mean, it's not there yet. It can help, but you have to deploy it in the right way. And we always say, both with my clinical hat, my academic hat on, and my entrepreneur hat on, we need to really be focusing on augmented intelligence more than artificial intelligence. And just blindly throwing this tech at existing workflows without understanding the workflow, you're going to create way more friction than you are going to remove it, especially in the clinical space.
Well, and that is an interesting, this is going to leap to policy, but it's an interesting set of conditions when we now have Doge and we have kind of this potential reality in our policy space today, where there is a very tech forward AI thinking potential administration, right? And we don't know yet, right? The CMS leads haven't been confirmed. So we don't know what that will look like. And RFK certainly hasn't spoken at all on any of that sort of stuff.
For me, I feel like it's hard to create more efficient systems if you don't understand the system. That's if you don't understand, the difference between Medicaid and Medicare and, the payout, like there are different levels of payment on each side. And so if you don't understand all that goes into a system, you may come in and kind of thoughtlessly just kind of shave things out. If you look at, Medicaid, Medicare as a payment system compared to other payers, it actually is quite efficient. And so I think that there is this misnomer of government waste associated with it. But it's like the admin overhead that happens there is actually a smaller percentage than a lot of, I don't want to call out people because they may be in the audience, but then a lot of current payment systems. And so that is my worry, is that if you have these folks who are not, folks look down on career government service providers, but they've been there for a while and they kind of know why certain things exist. Not to say that there are not inefficiencies. I definitely think that there are inefficiencies, but it's like you have to know the problem, understand the environment in which you're operating, and then you can go ahead and make the cuts or make suggestions for the cuts. I worry, to your point earlier, it's like when you come in with like a saber, then you have things like the whole CMS system being shut off, right?
Well, I mean, and if inside those four walls of CMS, we were already understaffed significantly. So for people like me who saw the backlog of 1115 waivers, like we were waiting on like 9,300 1115 waivers to even get approved. And by the time, it was like a drip right? Waiting. We knew that backlog was going to be like 3 or 4 years for those even to get done because there was workforce shortages. So like to cut even further was like horrifying to people like me, because that's people's like quality and duration of life, right? And this is like, and I look at it like our largest economic imperative in this country is our health. If we are not healthy, none of us can contribute to society, right? I mean, like that is our ability to actually make this country like perform. We all have to be healthy. If we're not at our optimal health, this country will not actually run. And no amount of machinery that I know of is going to be able to make it run any faster that I know of. I mean, I think that's what worries me is
you can't move fast and break things, because in healthcare, the things you're breaking are people, right? I tell my founders that all the time. Like, loved that slogan if you're just dealing with the social media company, but if you're dealing with someone's like healthcare, their mental health, etc., like what ends up breaking is people's lives, people's livelihoods, people's quality of life.
Totally. Yeah, and I think you bring up an interesting point too. Medicaid, Medicare, these are systems that have actually been catalysts for a lot of innovation and change. We probably wouldn't have been doing bundled payments in orthopedics or expanding our bundled payment programs to become mandatory in 2026. I'm hoping that remains the case. We wouldn't have had accountable care organizations without a lot of federal and state-based Medicare, Medicaid innovation. And I think we have to definitely highlight that. That's really important. I do think like there's some granular policy on my mind as we're moving forward, right? Like, are we going to see more block grants and more restrictions? Are we going to see
work restrictions?
Yeah. Are we going to see more requirements? There's a lot of really positive, because people respond to incentives, obviously. That's why we all of a sudden started seeing many more people screen for social drivers of health. It became a CMS requirement. I'm really hoping that things like that don't get thrown out, because that is going to really undermine a lot of the progress we're making. I think that I'm hopeful.
How are you going to keep social drivers of health? I mean,
Well,
it's a little nonsensical. Like,
Right.
how are you going to keep social drivers of health if you don't believe in health equity?
Yeah.
Like, I mean, that doesn't make any sense.
Yeah. So I agree with you. And I think that this is going to be an interesting sticking point too, in the way that they end up changing policy, because just a quick anecdote, like I have a hip fracture patient population. We've started screening for social drivers of health. That's a huge problem condition in this country that we've underappreciated, by the way.
Is there a social driver of hip fractures?
Oh, there's so many.
Tell us, please.
So we started screening all of our orthopedic trauma patients actually for social drivers of health about 2.5 years ago, when I first got to Duke. First off, before this, we had no idea whether people had food insecurity, transportation access, housing instability, and we kind of had a sense that dual eligible patients were more likely to come back to the ER. You know, we kind of saw that there were black-white disparities in osteoporosis treatment after hip fracture. But then you screen, so we just got some of our data back. 18% of our hip fracture patient population has at least one social driver of health impacting them. Since we started screening for social drivers of health, all of our patients who have had hip fractures have seen their treatment of osteoporosis go up almost by 30% since we implemented the program. And by the way, that population that has social drivers of health, 80% of them are white. So like I think that we kind of lose sight of the fact that the people that are dependent on these programs, the people that are going to benefit from these programs, you know, this is like not what the administration is seeing as the typical kind of EDI situation. This is my rural farmers, my construction workers, my laborers, and yes, also like my young black males. Like these are the people that I need to have that information on, and that if I have a resource to connect them with, makes a difference for their care, makes a difference for their outcome, and by the way, contains cost for the system and lets you maybe free up that bed for a commercial patient to stay, and maybe increases the throughput through your health system to ramp up the profits in a very thin margin system. We got to remember all that, and we got to keep highlighting and that story over and over again. And I think we have to be careful. We don't want to make it oppositional, right? Like, I just want to win. And this is the way to win.
Yeah, it's very interesting because when we first started at Health Tech for Medicaid, I would do these kind of teaching entrepreneurs about Medicaid, right? So we do these roundtables, and I would pull cohorts of entrepreneurs together and teach them, 12 and 15 innovators, and we do 5 or 6 sessions, right? And we teach them about Medicaid. And I'd always have a session where I'd bring in every single one. If you know much about health tech or Medicaid, we always have the voice of people on Medicaid as a part of our work, because we center people on Medicaid and their family, their caregivers, right, and their family members as a part of our work. Because if we don't center them, why do this work? And I remember the most interesting session we did was actually on pregnant women. And we used a case study of Georgia, which is a non-expansion state. So I did an expansion state and a non-expansion state. So case study in Georgia, and I had the Medicaid patient come on, and everyone in the chat was like, we're waiting for the Medicaid patient to come. Well, the Medicaid patient was there, but she was white. She had a PhD, but she had had both of her children on Medicaid. They didn't see a white woman with a PhD as someone who was on Medicaid, but she had come from a battered household, and she was absolutely on Medicaid. They expected a black woman who, didn't have many teeth, and I'm honestly telling you the truth. I'm telling you the truth because we have to dispel these myths. Who wasn't very educated. That was the perception. And until we have these conversations, and this is why we're going to do this tabletop exercise, until we have these honest conversations, we're not going to be able to get past, how community and capital markets and innovation kind of come together, right? Because that is the perception of what people think Medicaid is. And it's not. Why I started Health Tech for Medicaid, 1/5 of any hospital in this country's payments are Medicaid payments. That's how all of our hospitals in this country run, right? So if Medicaid goes away, I don't even know how our systems will work. And I'm not talking about public hospital. I'm talking about every hospital in this country. So, it's more important that we really, and so it just baffled me that when we go to JP Morgan, right, or I was always in the negative EBITDA corner in the back, right? And I was like, I'm going to make this my life mission that people start talking about this is the largest insured population in this entire country. Why aren't we centering this group of people? Because we believe that this is a discarded group, probably because we started with the word aid, right? Instead of care. And so I think this is a part of our movement. Is there anything we should talk about before we get folks to ask questions?
I will also say on the capital market side, some of the best performing companies in our portfolio are the ones who derive a lot of their revenue from serving, Medicaid and Medicare patients. And so if you are an investor and missing out or choosing to not invest in companies, I'm just saying you're missing out. It's more for me, but I think we can all be successful. And so we have had folks in our portfolio who come in, they start with commercial insurers as a pathway, to have enough runway to get into those markets. I mean, I won't say it's the easiest, but I would say once you have those contracts, they're pretty substantial contracts, and they have staying power because it's hard to get vendors in there. It's hard to get providers, especially on the Medicaid side. And so I think, to your point, it's not just aid. And so if you're doing it from a capital markets perspective, do it because it's also on the business side, it's a huge market. Yeah. What did you say? 79 million people? That's a lot of care.
It's $990 billion market.
There you go.
Anytime people are like, "Oh, I'm running a reproductive health care program. I'm like, or company. I'm like, are you in Medicaid? They're like, oh no, we're going to wait to get into that. I'm like, well, then you're not a business person, right? Like, because you're missing out on the largest part of the market ecosystem. I want to know, anyone have any questions for the panelists before we get into table? I'll move the mic around the room. Yeah. Hold on one second. Hold on.
I thought I would be the only practicing orthopedic surgeon here, but I'm really
What's up?
glad to see. I'm a hip and knee surgeon at University of Kentucky.
My fellow's out there.
Huh?
Brian Garrity.
Okay, yeah. Cool.
Is there an orthopedic competition or
No, we're buddies.
I thought I would be the only guy. So now there's a competition. Anyway, in terms of AI, I do have a comment and kind of a question to the panel because, back in 1995 when internet was kind of coming into vogue, we all thought that this will be the bright new age of humanity where everybody will get the information and all those stuff. And now, 25, 30 years later, we have different versions of truth to for everyone. But if you look at large language models and generative models, what we know is that at least we have a small window of opportunity where you guys were talking about like truth being like there is different truth to everybody, right? Like if you look at vaccination, what are the bad side effects of vaccination? Google, depending on who you are, where you are searching from, will get you different answers. But fortunately, at this juncture, if you are going to ChatGPT or anything like that, you will get more or less a similar answer from that system as to what are the side effects of vaccine. You can ask, is Earth really flat? Google might get you an answer saying that, yeah, it might be, because depending on which website you're going to direct to. But if you are right now looking at ChatGPT, it is going to push you back. So I think we still have some hope in terms of getting a unified answer for humanity. But it might change, 10 years from now, we will have different models for each one of us, which is going to tell you what you want to hear. But I think there is some hope, and I think we should look at that aspect of it, like using AI instead of trying to say, oh, AI cannot help. I do feel like AI can help. We have internet has kind of lost, to some degree, it is being utilized by bad actors. And until AI is being used by bad actors, we might have some hope.
I totally agree with you. Yeah, and so one thing we do is we have linked evidence and we use retrieval augmented generation so that all of the material that we're pulling in our model there's transparency to it. I think the more that we do that, and the more that we get domain experts building these models and involved in the vetting process, the better off we're going to be. If we just put a wrapper around it, there's still going to be errors, right, and issues. But you're right. There's like the beauty of transparency that we can build into these models and these innovations now. So it's actually like a tremendous opportunity, and you can do it in multiple languages. I mean, there's tremendous opportunity right now. I 100% agree. The medium of human communication is language, and we've never had an innovation that can actually be used to convey information like this. So yeah, I mean, I'm obviously excited.
Yeah, I think the issue, and the same thing you brought up, Google, for instance, of any tech is knowing its limitation. I think a good example of this is like if you guys go to ChatGPT right now, ask ChatGPT who the president is, right? It still thinks it's Joe Biden, which Trump would not be so happy about. But the issue is what it's training, like the subset it's based on. If you prompt it enough and be like, wait, what year do you think it is? Was there an election? Etc. If you don't believe me, like do it right now. I mean, I think, right? Thank you. Real-time confirmation. And so for me, I was like, what? And so you go to the vaccine, going back to your vaccine example, the great thing about medicine is that we're learning every day. We learn, unfortunately, new side effects come up, new comorbidities in terms of like, if you have this, don't do this. And so if you are utilizing AI, you have to make sure that whatever data set that you're training your model on is up to date so that people are getting accurate information and are not getting, a couple months past due information. Totally. We have a company, Scene Health, that does med adherence. They do like a video recognition of folks taking their medicine or their inhaler properly. they've used AI to help, expand the number of videos that they can screen. But this is after like almost, 7+ years of humans looking at it and then identifying what things that the machine then needs to look out for. So that's my only thing. Like I invest in tech, so I'm definitely not anti-tech. That would be a little awkward. But I just, as in everything, just being aware of the limitations of the tech that we're using.
Yeah, and then the last thing, I echo all those sentiments actually, and I would say for the investors in the room, for the decision makers at health systems, payers, et cetera, incorporate observability into your vernacular when you're talking to AI innovators and vendors, because it's like that's what you need. You need to be able to understand how well their agents are performing, where the guidelines are getting pulled. Do you have the opportunity to see how often the calls are failing or how often it's giving the wrong guidelines? And you need to have full transparency and insight into that. And I think that if you have that and you have the right people building the model and you have it vetted long enough, there's tremendous potential, but there are definitely pitfalls and risks too.
Hi, yep, you could hear me. Hi, everyone. Shannon Cosgrove. I'm the Chief Health Equity Officer at Blue Shield of California. Haven't figured out if and when I have to bury the lead on my title. Hopefully never.
Hopefully never.
But really appreciate the conversation and calling out what we're really grappling with right now. Would love to hear more on ROI. This has been a tough conversation for years, really being able to deeply invest in community, and particularly communities hardest hit by the inequities we see, and in order to see the long-term gains that we know will happen and need to happen, and these inequities didn't happen overnight and are not going to be fixed in a year. And so how, in this climate, have you seen, well, I can't say have you seen any success, we're all still grappling, but where would you advise us to really start looking and or making the case to further ROI in a real way?
I want to just pause for 1 second, because this is a great example of we will have state and federal tension. The state of California has a legal mandate that every single insurance company in the state have a chief health equity officer. And in fact, they met last week on Thursday to actually figure out how in the heck are they going to grapple with. They are required to have a chief health equity officer as a part of the law. And so now how are they going to address these executive orders? And what do they do in this title now? Like not only ethically, but also like just... So I appreciate, I want the answer to the question to be asked, but I wanted to preface that you're also walking around with this badge because it's a legal requirement in the state that you live in.
Yeah, it's a weird time for sure. And it's like, why, I don't know, I still don't understand why that one word is so triggering all of a sudden. I understand it, but to your point on return on investment, I think that we are seeing more and more examples of this, and how, in particular for me, the thing that I've kind of honed in on is the social drivers of health, because it's very tangible, measurable, and when you intervene on it, you can kind of track the outcome. So the American Healthy Communities Accountable Care Organization data came out recently, right? And they had people on an assistance track who were screened for social drivers of health. They found dramatic reductions in ED revisits and utilization in patients that got screened for social drivers and then had a navigator link them to resources for those social drivers of health. That's a great, kind of case study and example you can kind of roll out, like by focusing on this patient population, we are generating returns on investment by decreasing post-acute care utilization and cost of care. North Carolina, and I forget if it's Blue Cross Blue Shield or another payer, but they had a program where in their diabetic patient population, they screened for social drivers of health, had their food insecurity patients who just reported food insecurity, they gave them $60 worth of groceries. And they saw a reduction in the cost of care for those patients of $180. So, I mean, like, that's such a compelling, if they extrapolated that small pilot, if you will, they estimated that they would have saved $8 to $13 million in that patient population. I think, and maybe it's something that comes from this group, and we did it internally at Duke. I'm sure there are people doing it, maybe at the Gravity Project or elsewhere, but compiling like all that evidence for return on investment for these interventions that are focused on the Medicaid patient population, on dual eligibles, I think could be really, really valuable. And then putting that all into GPT and having it summarized. But I think that there's more and more of those stories coming out. And I still like, sometimes I'm just really like struggling. I'm like, why don't you see that story? Because it's just so obvious to me and probably to you and a lot of people in the room. Like, I mean, you have such thin margins and you're losing a ton of margin right here. And we've got all this data, but maybe we just haven't done a good job having that story be told by the data. And I think like if there are people that are interested in combining that data from different systems, we would love to do that with you at Duke and at Margolis. So definitely reach out. And I'm happy to provide examples to anybody who's looking for that data as well.
Yeah, so at Caper Capital, again, we're a venture capital fund, but as an impact fund, we have to show the impact our company's made. So we come out with our social impact report every year. If you go to capercapital.com, you'll see it. It's across industries. But if you look at the healthcare ones, again, I won't go through each company, but the ROI is clearly there. We're investing in for-profit businesses in order to have their contracts renewed. They have to show, lowered A1C, reduced readmission rates, et cetera. And so they are, and the great thing is the ROI is so great, they're actually now asking for like revenue, like outcome shares to be put into the contracts so that for the payers who see significant decreases in expense, like the founders, the startups can now realize a percentage of that because they were saving, these folks millions and millions of dollars, and the contract value kind of didn't account for that. And so we're now seeing that more and more, but a big piece of us is like combining that in our impact report. So we show our investors like, yes, on the money side, it looks great, but on the outcome side, here's the benefits that our companies are actually having in the healthcare space.
Yeah, we do outcomes-based payments in our contracts too at Revelai Health.
I was searching for
outcomes-based.
Yeah,
and like that's a huge lever to pull. It's kind of putting your money where your mouth is, so to speak. I will say like some of the returns that you can have, like the value on investment, some of it is tied to policy too, right? Like what's defined as care gap closure or a HEDIS measure, or how they decide what accountable care organizations are going to be held to account for. If that changes, then the equation could change and the CPT codes could change. So it will be an interesting next few years, but I still think that story of value on investment will continue to pan out.
Hey, I think I was up next, yeah. Hey everybody, good morning. My name's Spencer Hoover. I am the CEO and founder of the Clayton Company. I'm also, most recently, I was on point for Aetna's network Medicaid integration nationally into the broader organization. So integrating them with our MEU, Medical Economics Unit, for those of you who aren't familiar with the payer. Prior to that, I worked across markets in commercial Medicare and in IFP in specific local market conditions to address gaps, right, for care and find savings opportunities. The question about DEI is important because I came into that role at the lowest level I could find to get perspective about the payer itself. I found some great opportunities for us as a country to fix things at scale. One of the things that culture drives in an organization is the way you think about things, right? And what I found as a disabled airborne infantry soldier, went to Afghanistan and Iraq, is that we're focusing on the wrong thing when we talk about equity. I worked for UF Health and Henry Ford Health in Detroit. I helped Henry Ford establish service lines, wrote the playbook for them, and we took cancer off the ground as a demonstration project for the organization, focused on the patient at the center, and just to get to the end point, care pathways, right? The journey a patient takes through our healthcare environment. And so the concept of how do we think about DEI differently and still maintain the same focus about how we're helping patients in the community, especially disadvantaged communities. In the construct of healthcare, equity becomes, and this is what I experienced at Henry Ford. When I thought about equity, I was like, hell yeah, equity for patients, right? That's every patient, every American citizen should have access to the same healthcare, right? The same level of care. But we have a caste system in this country based upon the payer type you have, or if you're self-pay, or if you have payers that won't even go to your community because there's no profit opportunity. So I think in terms of an organization, DEI, like from a functional perspective, like a hospital or a payer, or like the groups doing the actual work in the space to help patients, the American dream should be driving through those organizations. You know, excellence, intelligence, execution, moral values, and, you know, getting the job done, no matter what you look like or where you come from. Equity, for sure, should be a focal point for all of us, for our patients. So I imagine a place for DEI executives to really reframe how they approach it and saying, I'm focusing on ensuring that we have absolute equality in identifying talent in our organization and putting them in the right place, getting rid of any type of constructs that are culturally, ideologically charged. At the same time, it's a bifurcated model for DEI experts now. Hyper-focused on getting in the community and identifying gaps, and then leveraging all the knowledge you've gained over the past 4 to 5 years in this exercise and applying it directly in the community, right? I'm coming to you because in this space, I'm here because I have a background in investment banking and valuations and consulting work. And I've kind of spent the past 20 years trying to figure out, like, how can we fix things? And I didn't have the last piece, the payer space. Like, what's going on with payers? It's a black hole. I don't understand how it works. On the provider side, you know, working in translation of science, like these academic medical centers, I found that those docs that are working on the front lines with patients and in the lab and trying to orchestrate getting funds for their idea, they hit a wall and get burnt out, you know, and that idea never makes it to fruition, and it goes off into the ether, right? And so all these constructs we have to get out of the way. So I wanted to understand, like, why is that happening? Why can't we get to cash flow for these ideas holistically in healthcare? So I quit my job at Henry Ford. I was going through my own space, right, and got a job at Aetna to figure it out. I've been working on an ER diversion project with VC-backed providers addressing intervention at 911 through dispatch or on scene. You may have heard of some of them. Many of them are here. But we're conducting, I basically attempted to work with them to thread a needle through Aetna's systems and CVS's systems to get an all product, all payers, right, national contract strategy in place from innovative providers in a phase 1. So 19 states and all products for these providers that get on board with the strategy. And it was intended to use as a demonstration project. What I learned from that are all the issues that you guys are talking about and all the gaps, right? And I have a founder here that's burnt out. He's trying to figure out what he wants to do, you know, because he's just hit so many walls. But his idea is amazing, and he's getting traction, but he's like, I don't know what I got to do. So in my mind, what it comes down to, we talk about the construct for VC in our country has to change. You know, I've done publications on, like, disparities in clinical trials.
Did you have a question for us?
Yes, the question is this. I'm trying to say, like, what do people think about the idea, excuse me, I'm sorry, doing a sandwich method for venture capital and private equity?
I'm not familiar with sandwich
using
method.
impact investing.
I like sandwiches.
Yeah, so the idea is using impact investing as a catalyst with the passions of whoever those founders are to feed as a supportive element for those folks that are falling out of the VC current world, to save them like Medicaid-focused individuals. And by the way, this ER diversion project came from Medicaid in Texas, a pilot in Texas, where you often find all the real innovation happening. So I'm positing that in the future, VC would be a world where it's philanthropically led, community-focused, and at the end of the day, founders of VCs and private equity groups should have, for healthcare specifically, should have a philanthropic mindset and maybe give whatever they create back to the world when they're gone. That's an idea.
I think that's great.
Sorry for being so long.
No, it's okay. I feel like that was the intention with, like, something like insulin. We see how that turned out. So, you know, I'm open to all models because obviously what we're doing right now is not working. I know you wanted to.
Yeah, I'll try to keep it brief. Stuart Johnson, I'm the co-founder of For Better Health. We are building a proactive preventive care coordination platform for the Medicaid population. For founders and for early stage companies like myself who are approaching the Medicaid market initially, I would love your feedback on the pulse of early stage VC. working with and partnering with early stage companies who are focused on Medicaid. As I walked in, I heard about the Medicaid market being nearly $1 trillion. They are long contracts, very great contracts to get. But from my perspective, there hasn't been as much VC focus on, again, Medicaid first innovators. For us, we've had the great ability to self-fund as well as get some really terrific family offices, individuals to help us on our journey. But as we begin our next chapter and engage in actually serving our first patient, we're looking for partners out there, but a lot of them, especially pre-revenue, it's been a challenge. So love your perspective on that and the greater early stage VC market for the Medicaid at large. Thank you.
Yeah, I mean, for me, I think it's seeking out like-minded individuals. So on the venture capital side, folks who are most likely in the social impact space, especially if you're pre-revenue, I think they see the potential of the positive impact your company can have. And so when you're doing research, I always tell folks like Crunchbase, things like that, TechCrunch, just Google in general, and ChatGPT. I've actually done this before to say like who are the investors who like investing in Medicaid businesses, and that will usually generate a list. And then most investors will have on their, and we have it as well, on their website, like all of the companies they've invested in. And so you can go in and see, because a lot of folks say they do things, but they don't actually do it, right? They're like, we love Medicaid companies.
That's my point, yeah. There's a lot of that, and I've done a lot of that research. I'm just curious, from your, are there a lot of people like you who also like the Medicaid space, social impact? Because, a lot of people say they do, but they don't actually.
Yeah, there's no one like me, but there are a lot of people who I think care about folks in this space. I feel like Adamika and her, there's a lot of resources on health tech for Medicaid. You can look at folks who've spoken on panels with her in the past. I don't want to hype you up, but great resources in terms of like the newsletter that is put out, and it will, she'll loop in other folks who are working in this space as well. I don't know if I'm missing resources.
Yeah, you're right. I mean, there's lots. It depends on how early you are. Seed, it's challenging pre-revenue, but there are some. California Healthcare Foundation, if you're doing some work in California, KPOR, there's a few more depending on what your model is and where your, what your service delivery is. But we can help. We have
if you stick around, I'm happy to send you. We've compiled lists for our founders, so happy to share.
I'd be happy to. And we raised and the whole thing, and it was hard pre-revenue. I think and maybe you've already done this. Obviously, it sounds like you're bootstrapping a little bit, and you've got family offices. We were in an accelerator. We were in the Techstars accelerator, and that kind of kicked us off a little bit. And then, once we had to cross the chasm into getting revenue, and I think that the 200,000 annual recurring revenue mark was kind of where people were like, okay, yes, we can invest in you. But before that, it was people were just saying no, So
I would say. I mean, I don't want to say it now because I don't know if it's still going to be there. But there were also a lot of government innovation grants specifically for folks who target those populations. I know probably 90% of our founders have gotten those grants to help at every stage, and so we love non-dilutive funding.
Yeah.
I don't know if that will still be in existence. Fingers crossed it will. But that's also another place
and we're watching all of that funding source. I mean, we're literally scouring and watching those funding sources and concerned ourselves as to whether or not SBIR and many other funding sources will still be around.
Yeah, SBIR, NSF, STTR. Mayo Clinic platform has an interesting accelerator. We're trying to build one at Duke. I mean, those are not rocket ship fuel sources, but I mean, it's
Cedars-Sinai has one. There's a bunch. I mean, we can talk.
Kaiser does grants. California Healthcare Foundation will do grants for folks who are not they have a venture arm, but they also have a grant arm. So looking at those sources as well.
We have one last question, then we're gonna hopefully dive in at tables so that folks can at least get to know each other and we can start talking about some of these questions. Yeah,
okay, I'll also try to be brief. So I'm April Joy Damian, also an epidemiologist from San Francisco. Frida Kipper-Klein was actually my mentor growing up in San Francisco. I worked at Kipper 20 years ago. But my question is, so I oversee the Weitzman Institute. We were founded out of a federally qualified health center. We focus in research, education, and policy. We work with over 1,200 health centers across the country. I was one of the brave souls that raised my hand, and I don't think I'm being recorded, but we received notifications from our program officers at NIH, CDC, SAMHSA that you have to remove this language, and had to submit it before I came here to our we have our own IRB of saying we're no longer going to collect SOGI data or mention DEI. I was trained in ethnic studies, so critical race theory, intersectionality, all of that had to be taken out, not of my own will, but because otherwise our dependence on federal funding would be pulled, right? And so I'm wondering, I'm looking at this beautiful Venn diagram. So I'm at the intersection of innovative partners in community, where all our education, research, policy efforts we do with community, with patients. They're co-PIs, they're at the conceptualization stage, at the proposal stage. But because historically we've focused on federal funding and now that is looking very uncertain, this is my first time at ViVE, at a health event. How do we create more opportunities for us in that space of the Venn diagram to be in the same spaces as those in private capital? Because I think sometimes I go to my research epi conferences, not these conferences, and sometimes we're just not in the same room and we want to serve the same population. So how do we create more of that? Because if it wasn't for our partner org, NAC, I probably wouldn't be here because it's cost prohibitive. So I'm just wondering,
So this is precisely why we're in this room, and precisely why we've been partners with ViVE with health since the very beginning. We were actually the very first partner with health from the very beginning, and why we partner with NAC, right? We are very close collaborators and co-conspirators. That exact reason. And I think you have to keep asking those questions. This is why we do this work, right? So that we can be in community together. And so I think it's a great segue, because I don't know that, for us to start being at tabletop together, because it's exactly right. I will just say our largest event is at JP Morgan, and you'd ask why in the heck would our largest event be at JP Morgan? Because nobody ever talked about Medicaid at JP Morgan ever. Because I, as a hospital leader, decided my sole reason was to make sure that Medicaid got mentioned at JP Morgan. And it took me a long time, but in 2021, we got mentioned on main stage, right? And that's why our main event is at JP Morgan, right? The NAC conferences, I was keynote speaker at NAC, right? We're trying to how do we get this audience to go to our conferences, right? And we've kind of we've pushed that threshold over, right? Now, I used to be JP Morgan used to not be very happy with my conference, right? Because I'd pull 500 and 600 people from the meeting. Now we're good, friendly friends. But that's what we also have to do. You guys, we need to come to ViVE and health, but they need to start coming to our conferences as well, and we need to be in the same space together. And that's ultimately what we're trying to do here, right? So let's spend some time together. What is on the table? Just so I can, I don't believe in speaking at people as much. So there's a bunch of leading questions that they're just to help you out. All of them have the same Venn diagram on them, but they have different questions. So one is really around ensuring capital reaches and benefits communities, right? So how equity and access and capital deployment. Another one is around strengthening public and private partnerships. Another one is around tech equity and innovation and Medicaid investments. These are just questions that you guys can ask yourselves, or you can just introduce yourselves if you want to, right? Another one on long-term sustainability of Medicaid and capital investments. What we learned last time is we don't even speak the same language, right? We don't even have the same terms that we talk about things in. And so our goal is to get to know each other, exchange cards, right? Have colleagues that we actually, because the challenge with us just coming to ViVE is you often don't actually ever get to ask questions of panelists, ever, on main stage or any other place. We never get to sit down at tables and actually say hello to each other and do anything. And that's why all of our events at ViVE have always been workshop-based, where we can kind of converse and work together. So we're trying. All right, let's get to getting to know each other, and maybe come together so we don't have one or two people at tables. And it's always an open door policy. We always keep our doors wide open. So if you need to leave, go ahead and leave. And thank you for coming.